Okay. All right. So we should be live now. And I just can't get myself to see what's being visible right now.
I'm trying to as well. It's on events, yes. I can't really find it for some reason. No, I don't want to create an event. I'm asking someone I know is there whether she can see us.
Okay, I see the was live. All right. If this is going live, thank you for your patience, everyone. Obviously, could have prepared a little bit better. Any response from the person that you were asking?
Not yet. She says she's still seeing the same 36-second clip with you and Ken. So no, she's not seeing it. She's still seeing the old clip, unfortunately.
Okay, all right. Let's try one more thing.
So it looks like you're live. You feel like we are live. Oh, it says Recover is live now. Let's see. It's a 36-second clip with you and Ken. So no, she's not seeing it. We're live, Ken. Still seeing it.
Okay.
I just don't know if it's
all right, that's great. That's a good thing. So hi, everyone. Thank you very much for your patience on all this. Now we are live, fortunately. And so thank you for joining us, those of us that are still here. My name is Ken Yagi. I am the Recover Program Director, and we are today doing one of our first short topic sessions, which is intended to have 5 minutes of one of the people involved in the Recovery Initiative presenting a short topic, and then followed by any kind of question that you want to ask related to that particular topic, or if you want to ask any other questions related to Recover that you've just been dying to ask, that's perfectly fine. That we'll be able to answer as many of those as possible today. And so obviously we have here today Dr. Fletcher, who is the co-chair, one of the co-chairs of the Recover Initiative, also one of the founders of the Recover Initiative. Some things that you may not know about him is that he has a pottery studio in his basement that he does his relaxation through. And he has a couple of very adorable dogs, but he's here to talk to us about CPR outcomes today. So please take it away, Dr. Fletcher.
All right, great. Sorry about the technical difficulties, but we're learning, and I'm sure the rest of these will go much more smoothly. So excited to be here and excited to see so many folks out there. I'm here to talk a little bit about CPR outcomes. Ken is indeed correct. I have a pottery studio in my basement where I spent most of the day today. So hopefully I'm nice and relaxed this evening to talk with you guys. So I just wanted to take it, this is literally 5 minutes, just to talk a little bit about what we know about outcomes in CPR to try to convince you that it's not futile. And I realize that most of you are not the people who need to be convinced of that. If you cared enough to show up for this event tonight, you probably already feel like CPR isn't futile, but I'm hoping that I can provide you with some arguments that you can use when you're talking to people about why bother with CPR and maybe to get them a little bit more excited about it. So this is a slide that you guys, if you've ever seen me speak on CPR, have probably seen before, but I'm going to go through it quickly with some additional data. Just sort of talking a little bit about what we know about the epidemiology of cardiopulmonary arrest. So if we think about sort of overall in CPR, if you have a patient who has an arrest at the time of the arrest, they're all alive, so we have 100% survival at that point. And this is a study, this is data that's getting a little bit old now, but there's not a lot of new data because this is stuff from a registry study that was done a long time ago. There is always updated data about survivals, and they're a little bit better than what we show here, but we don't have these nice large initial studies to look at. So I'm just going to start with this data. So at the time of the arrest, everyone is alive, and then we perform CPR on the patients who experience the cardiopulmonary arrest. And in people, they achieve return to spontaneous circulation in about 45% of those patients. So 55%, we never get a return to spontaneous circulation from. Then in that post-cardiac arrest period in people, we lose another 60% or so, and that leads to discharge rates of about 17%. Those are probably closer to 20 to maybe even 25% these days for in-hospital cardiopulmonary arrest. So this is sort of probably most similar to what we deal with. So patients who arrest in the hospital, as opposed to a person who maybe arrests out in public and has CPR performed there. So what do we know in dogs and cats? We do have some additional data as of last year, thanks to some folks at UC Davis. Sabrina Honey was first author on these series of 2 papers that were just published in 2019. And so if we combine that with the data we had from before, which was from the Hofmeister study out of the University of Georgia in 2009, we have a whopping 333 dogs and 90 cats across these 2 studies, so not quite the same magnitude of numbers. But if we look at return of spontaneous circulation, depending on which study you look at and which species, dog or cat you look at, return to spontaneous circulation is achieved somewhere between 35 and 55% of the patients, maybe a little bit better in the more recent UC Davis study than in the University of Georgia study. So that means we don't get ROSC in about 45 to 65% of those patients. The post-cardiac arrest period is a little more dismal for us. We have losses between 60 and 85%. Leading to discharge rates, depending on which species you look at and which study you look at, of 6 to 19%. So the 19% number is kind of exciting to me, and that's out of the Hone study, the more recent study out of UC Davis. So when we think about that 19%, who is that? That's actually cats who arrest in the hospital. So again, in hospital cardiopulmonary arrest at UC Davis, 19% of them in this study survived to discharge, which I think is pretty exciting and a pretty good number. When they compared it to their historical data, they didn't see a statistically significant difference in survival. But I do feel like we have a bad tendency to write off cats probably a little more than we should. So it's kind of exciting that these numbers look so good. So, but even then, 20%, right? It's maybe not the best number in the world. And if we're pessimists and we look at the worst number in this data at 6%, so should we really be even trying to do CPR if those outcomes are so bad? And I think it's really important to remember that not all arrests are created equally. So if we look at the original Hofmeister study, so this was back in 2009, this was before we had recovery guidelines, and this was a single institution, a tertiary referral facility at the University of Georgia. And if you looked at a subset of those patients, specifically the ones that arrested in the peri-anesthetic period, so these were likely animals that arrested due to the anesthesia, although there certainly were likely patients who arrested due to their primary disease, but if they're under anesthesia, there's a higher likelihood that they had some acute reversible issue. And if we look just at those patients, almost 50% of the dogs and cats who arrested in that peri-anesthetic period actually survived to discharge. So again, thinking about the cause of the arrest, these acute reversible arrests seem to carry a much better prognosis, up to 50% in these cases of these peri-anesthetic guys. So I think this is a really important piece of information for us to remember. If you just look at the abstract of that study, you say survival rates were 6 to 8%. But if you actually dig into the data and look at it, you can see that for some subsets of patients, the numbers are actually much, much more promising. And then if we look at this more recent data out of the University of California at Davis, they found that the patients who arrested under anesthesia, and again, this included this total outcome in cats of about 19% surviving to discharge. But if you looked at just the patients who arrested while under the care of the anesthesia service, they were almost 15 times as likely to survive as patients who were somewhere else in the hospital and were being managed through something else. And if you looked at cats, they were 5 times more likely to survive overall than dogs were. So I think there's a lot of data to sort of tease out here, but I think the important things to really key into here are that these patients who potentially arrest due to some reaction to anesthesia, and maybe if we're really optimistic, we can expand that thought to maybe patients who have other types of acute reversible causes of cardiopulmonary arrest, that maybe these numbers that we cite all the time, the 6 to 7% survival rate, is probably a little more pessimistic than we should be, because we know that there are these subsets of patients who can do a whole lot better. And this was just an email that I got at the beginning of the summer when I was feeling really low about the pandemic, from a colleague of mine, who just was reporting that they had 2 peri-anesthetic arrest cats who they had gotten back recently, and that their team felt very well prepared after doing the training from Recover, and really felt like they were ready to handle this, and they had these 2 really good outcomes. So I think, again, there's reason to be optimistic about these things, and we have to interpret the data that we have pretty cautiously. So thinking about the data, the limited data that we have available, I think there are kind of 3 major take-home messages for me. The first is that rather than thinking about those 6 to 7% survival rates, I think we should be talking about patients who are good candidates for CPR, patients who potentially have acute reversible problems. And I think we have pretty strong data that would suggest that at least 50% of those could survive to discharge, and potentially even higher, because that data is from before we actually had evidence-based guidelines as we use today. I think the second piece of information to really keep in mind when you're thinking about the data that's out there is that all of the published data, and there's not much of it yet, is from tertiary referral centers. So these are likely to be the sickest of the sick. And so as you're thinking about your approach to CPR, and as you're talking to your colleagues in different practice settings, I think it's really important to remember that, and to make sure folks understand that in many practice settings, I would argue in most general practice settings, and potentially a lot of emergency practice settings, where we're dealing with a lot of peri-anesthetic arrests, and we have patients who aren't quite as sick as they are at these tertiary referral centers, I think there's a reason to believe that we could do even better than those numbers that we saw in the Hofmeister and the UC Davis studies. So I would argue that this, to me, just says that knowing how to do CPR matters. And this is probably the biggest obstacle that I see to people improving these numbers and to doing good quality CPR, is just getting them to believe that CPR matters. And I would argue that we have pretty strong data to suggest that CPR does matter, that every veterinarian and every veterinary technician should know how to do CPR. And that if they do know how to do CPR, I bet we can eke these numbers up even higher than they already are, but they're already pretty optimistic numbers. So I just wanted to finish up by talking a little bit about why Recover happened and what this may have to do with this outcome data. So back in 2010, I approached Manu Bowler, one of the co-chairs of the Recover initiatives, who was a resident mate of mine at Penn and who was doing work in a human CPR lab at the time, about wanting to put together standardized CPR training. And this is really where the Recover guidelines and the Recover training program came from. And I thought he would be the best person to talk to because he was doing research in that area. And he said, yes, he would be very interested in working on this, but that he didn't know how to do CPR in dogs and cats because no one had explicitly ever asked that question or looked explicitly at the evidence to try to answer that question. And he shared some data with me before it was published, and then this was published as we were having these conversations. It was a survey study done through the Veterinary Information Network, asking people about their CPR practices. And this is one specific question from that study. This is the question of how fast should you do chest compressions in cats? And the answer to that question is this bar, this 100 to 120. That's to our highest level of understanding right now. This is the correct answer. And if you look at that bar in this graph among general practitioners, so this is general practitioners in practice who don't do a lot of emergency work, less than 30% of the folks in that practice knew that the correct rate was 100 to 120 per minute. And this is a fundamental thing that we know has a huge impact on whether we can get a return of spontaneous circulation and ultimately survival to discharge. So this very fundamental piece of information, there was a very low percentage of general practitioners who knew the answer to that question. And you can see there's a big spread with a lot of folks thinking you're supposed to go slower because that's what used to be taught back in the old guidelines when most of these people probably went to school. If we looked at general practitioners in emergency service, so not specialists, but emergency focused practices, the numbers were not much better. And then when we looked at board certified specialists, who you would think would know a lot, the numbers weren't really that much better. They were less than 40% who actually reported the correct answer to this question. So this really motivated us to say, okay, even if we could just teach what we know from experimental studies and a little bit of literature that's out there, we might be able to have a dramatic impact on outcomes because it seems like people just don't know because they're not getting regular CPR training. And so that's really what sparred the beginning of Recover and why Recover even exists and why we developed this evidence-based training for it. So last year, Manu and his colleagues at the University of Melbourne did a global survey again to repeat those same questions. And so if we look at this same question in cats now, so this was published just last year, the survey went out in 2018. So 8 years later and 6 years after the guidelines were published, how are we doing now? We're doing better. So this is, again, chest compression rates in cats. And this is the correct answer right here, 100 to 120. And so again, if you look at general practitioners who don't do a lot of emergency work, unfortunately, we're still just over 30% there. General practitioners who do mostly emergency, we're doing a little better, up at 40%. Board certified specialists, better, but still only 60% of them knew that this was the correct answer in cats. So I think this is really a fundamental issue that we need to deal with. And that's, if we can spread the word, if we can get people to understand that there's the possibility of good outcomes with CPR, and that there are simple things that we can do to tweak our approach to CPR, I bet we can eke those outcomes up even better. So for now, the cat is still a little bit grumpy, but we're hoping that we can fix this. And in the future, we can find that we can actually improve these numbers even more by getting people up to speed on how to do CPR. So how do we fix this problem? The first is to get trained. And you guys are all here, I'm sure, because you know about the training, but we do have standardized training through Recover. And if you haven't taken it, we really encourage you to think about it. Because it really will help to bring you up to the current level of our understanding about this. And then for most of you who are probably already somewhat Recover evangelists, encourage others. So I think the way you can do that is to explain to them some of the stuff that I talked to you about today, which is that these outcomes are not quite as bad, that when we look at that outcome data, we have to keep in mind that many of that is from referral facilities that are treating the sickest of the sick and these patients that have poor prognoses, whereas many of you are practicing in environments where there's every reason to think your outcomes could be even better than what we're seeing there. And also encouraging others to think about getting trained, because ultimately, once they know the algorithm and they know how they're supposed to do CPR, I think we have a much better likelihood of actually improving our outcomes. So that's just a brief introduction to the data that we have available. And I would be happy to discuss these. If you guys want to post any questions or comments you have in the chat, or if you have other questions that you want to bring up, that would be great. So it looks like there are some things out there. Ken, I don't know if you've been keeping an eye and if there are specific themes that are coming up that you'd like me to address.
Yeah, the first question that I see is why are cats more likely to have a successful CPR?
Yeah, it's a good question. So one of the many questions that I think we love to try to answer. I have some theories. You know, I would say my strongest theory is just that it's very easy to do chest compressions on cats, and it's very easy. I feel like when you do chest compressions in a cat, you can almost feel the heart in your hand, right? Because they have very, very compliant, very narrow chests, and so I think we can get really good compressions. And we're just starting a study here looking at trying to optimize chest compressions in cats. And I've just had a couple. We're doing this in actually cadavers and cats after they've been euthanized for medical reasons, where we're then doing chest compressions on them and measuring pressures. And I've been pretty amazed at, just with our preliminary work that we've done, at the aortic pressures that we can get by doing just the manual one-hand chest compressions in cats. So my suspicion is the reason they can do well is because we can probably do compressions really effectively in them. But I think it's a really important question that we still need to answer.
There's a couple of comments, Dr. Fletcher, that Ekta says that you taught how to perform CPR at Cornell, and she feels that this is very important.
That's good to hear. Excellent.
And Chantal is asking, are there any future plans coming that will require VEX certified facility and AHA practices to be required to be certified in Recover CPR to get the certifications?
Yeah, it's a really good question. So it's something that we've certainly been working on for a long time. It's not an easy thing to enforce. I think that there are a couple of barriers to that, and I think we're going to keep working on it. And I think those of you who are out there in the field and talking to these organizations, it would be great for you to chime in and tell them that you think that's important. AHA, I think, is something that we'll keep having conversations, and I would love someday to get to the point where they require that at least whatever certification they use, whatever CPR training they use, because it is a requirement for AHA certification that there be CPR training. It's just that it doesn't specify specifically what type. And I think that at least saying that it's Recover compliant would be important. Obviously, I would love for it to be the official Recover training. For VEX, it's a little bit challenging, and we've talked about it, and definitely I think it's something that may come down the pike. There's an inherent conflict of interest, right, because Recover is part of VEX, and then requiring people who go through the VEX facility certification to do something that's a VEX project. There's an inherent conflict of interest there, but I also think that as Recover is becoming more accepted, I'm hoping that that'll be less of a barrier. So I would like to see that happen. So we're continuing to discuss that, and to the extent that you guys out there can talk to these organizations and let them know that you think that's important, I think that'll be really helpful.
And specifically for VIX, the Facility Certification Committee is taking a look at updating the standards, and it does at least say CPR according to the Recover guidelines.
Yeah. Yeah, so I see a question as well about end-tidal CO2, a couple of questions about end-tidal CO2, so I can jump into that one quickly, and then I know there's one before that we'll get to as well. So there was a question about, is end-tidal CO2 still considered a good indicator? And a question asking, what do you do if you're doing CPR according to the guidelines and you can't get your end-tidal CO2 to come up? So end-tidal CO2 definitely, we think, is probably one of the better markers that we have of your effectiveness of your whole approach to CPR, but really importantly, your chest compressions. So yes, it's definitely still considered vital. So there are a couple of things that I would do if I'm doing CPR and my end-tidal is not coming up. So my target is 15 millimeters of mercury. If it's less than that, I'm going to take that very seriously, because that means I'm probably not getting the best blood flow. So I'm going to adjust my approach to chest compression. So I may move to a different part of the chest. So if I'm using the cardiac pump approach, I might switch to the thoracic pump approach. I'm certainly going to look very critically at the chest compression quality. So make sure the depth is okay. Ask someone to watch me if I'm the one doing them, because it's really hard to tell when you're doing chest compressions how deeply you're compressing. So have someone else evaluate it. And if all of that, and also obviously evaluate your ventilation. So if you're not ventilating at the correct rate, at 10 breaths per minute, that's not going to work either. If all of that stuff is done and your end-tidal is still not coming up, then most likely that means that your tissues are so ischemic that they're just not making CO2 anymore. And that's a very poor prognostic indicator. So for me, if I've really critically evaluated how I'm doing CPR, if my basic life support is really by the textbook and I feel like I've tried everything I can and that end-tidal won't come up, then that's one that I'm probably going to say I'm going to call that code a little earlier than one where I have a really good end-tidal CO2, because that probably means the tissues are really ischemic. The other possibility is that you've got a big clot somewhere that's just obstructing blood flow, and that you're not going to be able to overcome during CPR either. So again, just really critically evaluate your BLS, and if you really feel like you're doing everything you possibly can and that end-tidal won't come up, then I would say that's a code I would be comfortable calling and saying we're not going to get this one back. There was one before that. How long should I do CPR on my patient? And this is a question I get very, very frequently. And for me, that completely depends on the cause of the arrest. So like I talked about in that little brief talk I gave at the beginning, if this is a peri-anesthetic arrest in an animal that doesn't have a really bad disease, and I'm maintaining good end-tidal CO2, so I've got an end-tidal CO2 of 20, and this patient has an acute reversible problem that I know I can fix, I will go a long time on those. The longest I personally have ever gone is 45 minutes and gotten a patient back and out of the hospital. I've talked to people who have gone longer than that and had successful CPRs. So those are the ones that I would fight for. I make this joke all the time, the 20-year-old cat with renal failure, heart failure, and abdominal mass and DKA who arrests in the ICU, you know, that patient didn't actually have a cardiopulmonary arrest. That patient died, right? That patient has multiple diseases that I can't fix completely. And most likely the reason that patient had that arrest is because the disease processes have caught up. I'm not going to get that one back. And so I'm certainly not going to go 45 minutes on that patient. So I think it's really about patient selection, right? I don't think there's any reason not to do CPR in that 20-year-old cat. I absolutely would do CPR if that's what the client wants. It's an opportunity for your team to practice and to get better at CPR. And it's an opportunity for the client to get the closure they need to know that you've done everything you can. And that can mean a lot to a client, and it's no harm to the patient to do it. So I would still try it, but I certainly wouldn't go 45 minutes on it. So how long is long enough is a really difficult question to answer. I think it sort of comes down to your comfort level and what you think you can do at your practice. But again, I've talked to people who've gone an hour and sent patients home. So I wouldn't give up easily on the patients with acute reversible diseases.
Dr. Fletcher, as a follow-up for the ETCO2 question, is ETCO2 still a viable option to use on congestive heart failure with severe pulmonary edema, or is there another method to monitor effectiveness?
Yeah, it's a good question. I do think it's still a good monitor to use as long as you don't trash your monitor by doing it. So if there's a lot of pulmonary edema coming up through the tube, it is possible that your end-tidal CO2 monitor will stop working. You have to, sort of set things up. So if you have a side stream monitor, the one that has the tube off that aspirates air, just make sure it's turned so that the tube is pointing up, so that it's not going to get as clogged with fluid. If it's a mainstream end tidal CO2, you're going to have to make sure that if it gets full of fluid, that you suction them or dump them and get all that fluid out of there. But it's still the best one we have. And unfortunately, the reality is we just don't have a lot of other monitoring options during CPR. End tidal is the best that we probably have. And patients with any kind of significant pulmonary disease, there is the risk that it's not going to be as accurate. But as long as you can get that device to read, I would still look at it and try to use that data.
Next one could be, is compression rate for rabbits and guinea pigs the same as dogs and cats?
Such a great question. And I wish I could tell you I knew the answer to that question, but I don't, because no one has studied it. So it's interesting you asked that. So the study that we're just starting now in cats, one of the motivations for that is to have a model that we can validate, that seems to work, that we can try in other species, because we just don't know. When I do CPR in guinea pigs, which isn't that often, but when I do CPR in guinea pigs, I still target about 120 compressions per minute. It's frankly a little bit hard to go a whole lot faster than that with manual chest compressions. You could make the argument that maybe you should go a little bit faster, but we just don't know. And I think this is one of those many pieces of low-hanging fruit that we really need to go after to try to figure out. So I think rabbits, guinea pigs, and birds as well are species that I think we just know so little about. So we've talked a lot about, we're in the middle of the guidelines 2.0 process right now, writing new guidelines for dogs and cats. And we've been talking a lot about trying to convene a panel after we're done with the dog and cat guidelines of exotics folks to maybe try to take a look at that same literature and see what questions we can answer, and to at least get some experts around who have experience, who might be able to offer up some opinion, and also to identify the knowledge gaps, which is such an important part of what Recover does, is identifying the really important knowledge gaps that we need to fill by looking at the evidence and seeing what's missing. So I think I'm hoping that after the 2.0 process is done, that we can actually start to make progress on that and try to answer some of those questions. So for now, I would probably still target 120 personally, but there are probably many people out there who have a lot more experience than I do who might be able to offer you their input as well.
The next one says, should you always confirm CPA before starting compressions?
Yeah, that's a really good question. And I would argue we always recommend a quick airway breathing assessment. So always, but that shouldn't take you more than 10 to 15 seconds. So in my opinion, if a patient is non-responsive and is not breathing, it's very reasonable to start CPR regardless of whether you assess whether there's blood flow, whether there's a heart beating. Because if the patient's not breathing, if his heart's beating now, it's not going to be beating for much longer, and it's likely going to stop very soon. The guidelines currently say you shouldn't check a pulse because it's a very unreliable measure. It's very easy to think you feel a pulse when there's not one there, and that could prevent you from starting CPR when you should. I still feel a pulse because I'm an old man and I can't change my ways, but I make sure I don't spend more than 10 to 15 seconds. And if there's any question in my mind that the pulse is absent, I'm going to start CPR in the apneic patient. So really, I would say the only time I wouldn't start chest compressions in a patient who's stopped breathing is if I have some sort of additional monitoring device on them that's showing me that their heart is still beating, and I have time to just intubate and ventilate and see if that prevents the arrests. But in most cases, in an acute setting, I wouldn't delay starting chest compressions because it's not quick and easy to get an assessment of blood flow.
Can you do CPR on a large animal like a horse?
Very good question. So we sadly, for the first round of Recover, our large animal domain never kind of gelled, and we weren't able to do the full guidelines process for large animals. The good news is for the Recover 2.0 process, we are absolutely doing it. And we're asking questions about adult horses and about foals. So we're doing both adults and neonates. So stay tuned. The large animal folks, I would say the opinion is a little bit split about whether chest compressions in adult horses have any hope of causing blood flow or not. So this is one of those questions that we really want to see. There's not going to be a lot published out there, but getting a group of large animal experts together to sort of talk about that and maybe to think about some ways to answer that question, I think will be really important. So it's tough for me to answer that question because I haven't dealt with a horse. I did do CPR and an adult California sea lion once, who's about the size of a horse. That did not go well. I did knee drops on him, but I don't have personal experience with horses. So stay tuned. We hope that by next year's IVEX, we'll have those guidelines ready for release. And I see Linda Lasky on there about the seal. Yes.
So if you have any further questions, please type them in now. There's a couple of questions related to certifications and such that I'll just quickly answer. That one of them is certification hands-on lab or online? And the certification process starts with an online course on basic life support and advanced life support, which is then can be followed up by an in-person lab that uses simulations that will certify you as Recover Certified BLS or and ALS rescuers. And there's a request for a Recover CPR program handbook that maybe contains information about. We have a quick reference guide now that shows some of the key information, like the algorithm and the drug chart and the ECG diagnosis algorithm, but we don't have a handbook yet. But
yeah, but I would say what we do have is the manuscript, right? So the Recover guidelines are published in an open access issue of JVEC that was published in 2012 in June. You don't have to have a subscription to JVEC to get it. And if it's a full issue, but the part that you would want would be the part 7 of those manuscripts, which is the actual guidelines. It's got the algorithm, it's got the drug and dosing chart, it's got a full description of how to do CPR to the highest level of our understanding, as well as post-cardiac arrest care. So remember, that's out there, and you can access that at any time. There's a link on the recoverinitiative.org website, on the vex.org website, or you can just search for Recover Guidelines JVEC and you'll find it.
I just put the link in for the Recovery Guideline page on our website in case you want to take a look at that.
That's great. And I see there's a question about, are there hands-on labs in Canada? What about during COVID? I've told Ken this many times. I went into a little bit of a spiral of depression in the spring of this year because I've sort of dedicated a decent chunk of my professional career to immersive simulation and CPR training. And it kind of all seemed to be evaporating when COVID started. We are working on a process to try to cover those same skills via an online platform. So we're calling it telesimulation. And we are also working on a basic life support online workshop where you can take the online course first, the didactic portion, and then you can do the hand skills and practice them remotely with an instructor. So all of that stuff is stuff that we're working on right now, and we hope will be released in the next few months. So there hopefully will be options soon for rescuer training that won't require people to gather in person. And then we're also hoping that soon we'll be able to gather, well, sometime in the not too distant future, we'll be able to gather together and get back to doing hands-on training. But in the short term, I would say you can gain a lot by doing the online training, and you still get a certification, the first step of the certification from that. So I really encourage you, if you haven't done that, to consider it, because you'll really learn the basics there. So I see a question that says, apart from recovery training, what is the most important thing a general practice can be prepared for CPR? I would say the most important thing is making sure that everyone in the practice is comfortable with the algorithm. So, if you put an algorithm chart up on the wall, but you've never talked about it, that doesn't really help you. It's just a piece of paper on the wall that no one understands. So at a minimum, making sure that your staff is comfortable with basic life support. So how to do chest compressions, how to ventilate, really so important. And if they're confident to do that, then they're going to be much more likely to jump in the midst of a crisis. And really that basic life support, we know that that's the most important part of CPR. So if everyone is trained in that, and you don't need anything fancy to do that, right? If you learn how to do it, again, at a minimum, you can just read the guidelines and everything is spelled out there about how to do basic life support. And then just go to IKEA or go to Target and buy a stuffed dog. Stick some sort of ball in the chest. Nerf footballs work really well. The little ones, you can put those in the chest to give you a little recoil, and just have people practice, just do it. And I think that by itself can have a huge impact. If people feel confident that they're ready to do that and they're ready to jump in if an arrest occurs, because getting chest compression started right away and ventilating right away, those are the most important part of CPR.
Any updates on VetSim, says Rick.
Yes, Rick, there are updates on VetSim. So VetSim is currently available, so there's a version of it that's working. If you're a certified instructor, which I know you are, you have access to the scenarios and you can use it now. You could use it right now. The problem is that it only runs under the Ubuntu operating system, and that's been a little bit of a barrier to some folks to get it up and running. We are working on a couple of things right now. One that we're working on is expanding the capabilities to do this telesimulation that we talked about. So stay tuned. There's going to be information coming out about that soon. We have done a first run through with that, and we have some changes being made by the developers. The other thing that we're exploring, because we recognize that this thing running under Linux has been a challenge, is we're looking into the possibility of porting it so that it would run under Windows directly. That will take a little bit longer to do, but we're looking into whether that's going to be feasible. So stay tuned for that. But you can get VetSim right now. You can reach out to us at any time. Reach out to, you can just send an email to Ken or to me, and we can send you the instructions for downloading it and installing it and how to get it up and running.
Excellent. So how important is it to have a properly fitting ET tube, or is establishing airflow more important? Sometimes smaller size tubes are grabbed and leaks are heard, even with the cuff inflated.
Yeah, so if there's a leak, you're not actually, if there's a leak in the endotracheal tube and you're doing chest compressions simultaneously, there is not any way that you're ventilating that patient, because anytime someone is pushing on the chest while you're delivering a breath, that breath is just coming right back out around the endotracheal tube if there's not a seal. So having an endotracheal tube with a good seal is critical. If you don't have that, you're not ventilating the patient, and you actually have to do effectively mouth to snout ventilation for those patients. So you have to pause chest compression. So give 30 compressions and then give 2 breaths. And I would only do that until you have the right sized endotracheal tube. You need that seal. That's really important. And there's a comment from Leslie about if only VetSim were Mac friendly. Yes, I know. It's a very large development project that we took on, and just supporting multiple operating systems is a real challenge for us. Maybe one day I'll hit the lottery and we can afford to do it on all the different platforms, but for now we're a little bit limited. Any other questions anyone would like to ask or comments?
A new one just came in. Are veterinary technicians allowed to call and run a code if a veterinarian is not immediately available?
Yeah, it's a really important question. So we did ask some PICO questions about this in the recovery guidelines, and in terms of running a code, the evidence certainly supports that the person with the most training and the most experience, regardless of what their title is going to lead to the best outcomes in CPR. So we did say specifically in the guidelines that whoever is the most experienced person should be the one running the code. Whether a veterinary technician can run a code without a veterinarian physically present would depend a little bit on the local practice acts. The most practice acts allow veterinary technicians to administer medications and to perform procedures that they're trained in, as long as there's a standardized protocol available. So the idea is that sort of indirect supervision. If a protocol is in place that's been approved by a veterinarian, then it's okay for the technician to do that. Here at Cornell, we did look into the New York State Practice Act, and we felt that it was pretty clear that as long as that protocol was in place, established, the people were trained, and they were following the protocol, that it was fine for technicians to do basic life support and also to administer drugs according to the drug and dosing chart and the protocol. Again, you have to look at your local practice acts in the United States or wherever you're practicing if you're not in the US to see what's legal and what's not. And then obviously really important to have that conversation at the practice level to make sure that everyone is on the same page. But my understanding is that in most states, the Practice Act is such that that type of thing where there's a protocol in place that's been approved, that would be considered indirect supervision and should be okay. But again, I would encourage you to check your local practice acts. I see a question, can you share an algorithm? I assume you mean the basic life support and advanced life support algorithms. So those are in that part 7 of the manuscript. Ken posted earlier in the chat the link to how to get to that. But if you just download that part 7, that PDF, the algorithm, the basic and advanced life support algorithm, and the drug and dosing chart, and a post cardiac arrest algorithm are all in that. So you can get all of them right from there. If you want the official wall size poster charts, VEX does sell those. You can go to the vex.org website and go to the store. I think they're 15 or 20 bucks for a poster size of either of those. So you can also get them there, but they're in the manuscript and you can print your own. Let's see, I'm looking to see if there's anything else. So Rick, I guess just another thing about VetSim takes up a lot of space. I guess the manual about installation says that you need like 250 gigabytes or something. They were just sort of trying to prepare for the worst case scenario. It's not that huge, but it does require a whole separate operating system. So I agree, it's complicated to get it running. I agree. I hope that IVEX 2021 will be in person, and I hope it's safe for us to start to do labs there again, because we miss doing them very much. Any other questions before we call it a night? You guys were very energetic for a post-Thanksgiving conversation in the US. Thanks for all the questions. All right, if there are any more questions, just a reminder that we're planning to do these every month. So there's one scheduled for December and one scheduled for January. Ken, maybe you can jump on and share the dates, because I don't know them off the top of my head.
Yeah, so I'll at least give the December date. That it's December 11th at 8 p.m. Dr. Buller will be talking about how CPR was invented. So it should be a pretty interesting topic. And we'll have one in January as well, but we'll post events on the Facebook page as soon as we get off here.
Absolutely. All right. Well, thanks everybody for coming. It was really nice to see such a great turnout for our first attempt at this. Sorry about the snafu, but I think we now know how to do it. And hopefully we'll have many more of these in the future. Have a great weekend, everybody. Take care.
All right. Thank you, everyone. Have a good night.